Migraine is a chronic neurological disorder that can severely impact quality of life. It has a strong genetic component and is often underdiagnosed and undertreated. Patients often complain of intermittent headache, which is often associated with visual disturbance, nausea, photophobia, and phonophobia. It usually presents in early to mid-life. Before we continue, don't forget to subscribe and hit the notification bell. Let's start with its pathophysiology and clinical features by breaking down the 4 phases of a migraine attack. The prodrome, which is thought to be due to hypothalamic activation, consists of affective or vegetative symptoms including yawning, fatigue, as well as altered food cravings. It can precede the rest of the migraine by hours to days. 1/3 of patients experience an aura, which is thought to be caused by cortical spreading depression. This is a self-propagating wave of neuronal depolarization that spreads across the cerebral cortex. This cortical spreading depression actually corresponds to the aura's symptomatic spread. Auras may manifest as almost any neurological symptom, but it's most often visual. A visual aura classically begins as a small area of visual loss, often just lateral to the point of visual fixation. It then expands and forms geometric shapes or zigzag lines around the border. The aura usually takes around 5 minutes to an hour to evolve. The headache is the 3rd phase of the migraine. The previously discussed cortical spreading depression then activates the trigeminal-vascular system, which causes the release of vasoactive peptides, including calcitonin gene-related peptide. This is a group of sensory neurons that originate from the trigeminal ganglion and innervate cerebral blood vessels and dura mater. After their activation, they cause the headache and sensitize the body to nociception. The headache of migraine is often, but not always, unilateral. It tends to have a throbbing or pulsatile quality, especially as the intensity increases. Patients frequently experience nausea and sometimes report photophobia or phonophobia during attacks. The headache usually lasts between 4 hours and 3 days. After the headache resolves, the postdrome starts. Patients often feel drained or exhausted. Sudden head movements transiently cause pain in the location of the headache. This phase usually lasts 1 day. Diagnosis can be made using the International Classification of Headache Disorders. Migraine with aura require one fully reversible aura symptom, which can be described with 3 of the following. It spreads over 5 minutes, lasts 5 to 60 minutes, is unilateral, is a positive neurological sign, it's accompanied by headache within 60 minutes, or 2 or more symptoms occur in succession. On the other hand, migraines without aura can only be diagnosed when there's a history of 5 attacks where headaches last from 4 hours to 74 hours. They must be associated with either nausea and/or photophobia, and have 2 of the following features: unilateral, pulsatile, intensely painful, and aggravated by exercise. Let's move on to the pharmacological management of acute migraines. Treatment for acute migraine aims to abort the headache stage of the migraine within 1 to 2 hours. It should be started as soon as possible. As an initial treatment for acute migraine, try a non-opioid analgesic like aspirin or ibuprofen. When the response to a non-opioid analgesic is suboptimal, consider adding an antiemetic, in particular metoclopramide, which is a D2 receptor antagonist. As there is dopamine receptor hypersensitivity in migraineurs, metoclopramide is effective in aborting migraine attacks as well as being an antiemetic too. If this hasn't been effective, triptans, which are a 5-HT1 agonist, can be trialed. Triptans arrest nerve signaling in the nociceptive pathways of the trigeminal-vascular system and are particularly effective abortive medications. As they cause vasoconstriction, they aren't really recommended in patients with cardiovascular disease. Elatriptan and rizatriptan have the highest pain-free rates at 2 hours, while naratriptan is associated with lower adverse side effects. Prophylactic therapy is generally indicated in patients with 3 or more severe headaches per month. All oral prophylactic drugs for migraines were developed for other purposes such as hypertension, depression, and epilepsy. Patients should be counseled that the clinical response is judged after 2 months of treatment, with at least 50% reduction of migraine days considered significant. Some prophylactic options include amitriptyline, which is a tricyclic antidepressant, candesartan, which is an angiotensin II receptor antagonist, propranolol, which is a beta blocker, and topiramate, which is an antiepileptic. In Australia, if a patient has a chronic migraine but has failed to improve with 3 oral prophylactic medicines or just couldn't tolerate them, they qualify for PBS subsidized botulinum toxin A therapy. This is given by a neurologist and requires 31 injections subcutaneously in the head and neck every 3 months. A new class of prophylactic injectable monoclonal antibodies targeting the calcitonin gene-related peptide have recently emerged. They're given as monthly subcutaneous injections and appear to be well tolerated. In Australia as of 2022, they can only be started by a neurologist. Thank you so much for watching Townsend Teachings. Don't forget to like, comment, subscribe, and hit the notification bell for further updates.